Hello, I'm Tony DeMaria, the editor of JACC, and I'm here for another edition of the Genuine Article. Today I want to talk about several interesting papers that are about to appear in JACC that all deal with the same topic, that topic being erectile dysfunction, particularly in patients with diabetes. Now, the first manuscript comes from the Chinese University in Hong Kong, and it's published by Doctors Ma and Tang. And these individuals managed to identify 2,300, slightly more than 2,300 patients with diabetes, nearly all type 2 diabetes, and who were asymptomatic from coronary heart disease and had no evidence of coronary artery disease. And they prospectively followed these patients for 4 years. At the end of 4 years, what they identified was that there was a significantly greater incidence of major coronary events, that is, death, myocardial infarction, or other coronary syndromes, in the patients who had erectile dysfunction than in those diabetics who did not have erectile dysfunction. And needless to say, the patients with erectile dysfunction had a number of other coronary risk factors. They tended to be older and have diabetes for a longer period of time and have more severe lipid abnormalities, renal dysfunction, microvascular disease. But nevertheless, even after accounting for all of those differences, the risk of a patient with erectile dysfunction having a coronary event over this 4-year period of time was increased by about 50%. Now, there was a second study. This second study came from Italy, and the major author was Dr. Gara Russo. I think I maybe mispronounced that name. It's Dr. Gassa Russo. In any event, in this particular study, they managed to identify 231 patients with diabetes who were asymptomatic but were proven angiographically to have coronary disease. Now, these individuals were identified as part of a study in which stress testing was routinely performed in diabetic patients. So these 231 patients were again followed for the same period of time, interestingly enough, 4 years. And what was observed was that erectile dysfunction was twice as common in the patients who exhibited MACE, or major adverse cardiovascular events, during that period of time as in those patients who did not exhibit adverse events. So twice as much endothelial dysfunction. Even more interesting in this second study was the fact that they looked at the modifiers of risk in these patients, and they found that both statin use and the use of phosphodiesterase 5 inhibitors, that is Viagra and the other drugs, sildenafil, vardenafil, tadalafil, all were protective of coronary events. And this was to a certain extent unexpected, but nevertheless, clearly the statin benefit was obvious. The benefit of the phosphodiesterase inhibitors fell just short prospectively of being of statistical significance. Now, Dr. Robert Kloner of Los Angeles editorialized both these papers and put them in perspective. I think it's clear now that these two studies, which were both prospective and really important from that perspective, clearly cement the idea that erectile dysfunction is a major risk factor for coronary events, particularly in patients with diabetics, that erectile dysfunction often precedes coronary artery disease symptoms, and that it may be a harbinger of events that could be prevented. In this regard, it's pretty interesting that not only statin application, but potentially the use of phosphodiesterase 5 inhibitors may be beneficial in these patients with erectile dysfunction. And clearly, historically speaking, we know that Viagra, sildenafil, was initially evaluated as an anti-anginal drug. These phosphodiesterase inhibitors have beneficial effects on endothelial dysfunction, and so there is a mechanism by which they would be of benefit in coronary artery disease. In fact, Dr. Kloner went so far as to suggest perhaps the time has come for a randomized trial in this regard. Whether that will happen or not, I think putting these three articles together, the two original articles and the editorials, we can take away the fact that we really need to intensively question our patients for the presence of endothelial dysfunction, particularly our diabetic patients. Now, historically, it's interesting to recall that sildenafil was initially evaluated as an anti-anginal drug, and that all of the phosphodiesterase inhibitors, in fact, improve endothelial function and have a vasodilatory effect. So there's clearly a mechanism by which these agents could be of benefit in reducing major coronary events in our patients with erectile dysfunction. And in fact, as Dr. Kloner points out in his editorial, there's a number of experimental studies in animals which have shown that these phosphodiesterase inhibitors can actually reduce infarct size and produce some other beneficial hemodynamic effects. So we really do have a mechanism by which we can assume that the administration of these phosphodiesterase inhibitors could, in point of fact, benefit our patients with coronary disease and erectile dysfunction. Now, there's still a certain sexual stigma that comes with identifying sexual dysfunction, erectile dysfunction, but nevertheless, I think we need to probe in that area, and we need to very, very aggressively treat those patients who do have erectile dysfunction for all of their coronary risk factors, and perhaps sometime in the future, our patients with erectile dysfunction will benefit not only in terms of sexual performance, but in terms of preventing major events due to coronary artery disease. For the Genuine article, thanks a lot for viewing this. I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.